Hi, I'm Dr. Ferris. Today let's talk about nasal sprays, specifically in relationship to allergic rhinitis. I'm targeting this video mostly towards providers, so that's doctors, mid-levels, and of course students as well. Today we will go into some of the mechanisms of action and some of the specifics, but mostly I want to go over the reasoning behind them. Let's quickly do an overview of the sprays that we're talking about today. These first couple on the left, the spray and then also the neti pot, these are the over-the-counter ones, and then Flonase, or the generic, is also over-the-counter. We'll do an antihistamine that's prescription only. We will do an anticholinergic that's prescription only, and then there's the famous Afrin generic oxymetazoline. I like to break up nasal sprays into categories. The first category is something that can wash out irritants, allergens, anything like pet dander, any of the pollens from grasses, trees, anything like that. And it really just flushes out a lot of that, so you have less time to make an allergic response. And also it keeps the inside of your nasal mucosa a little bit more moist and a little bit less likely to get that friable, just irritated feel to it. The first one I use is called Simply Saline. This is a brand that I really like, partially because it's available in pretty much any pharmacy around me. It's available at Costco for pretty cheap for like a 3-pack. And as they make very clear, it's drug-free, which just basically means it's literally just salt water. Now this version is the brand I like, but there are certainly other brands out there. But I like it because of the convenience of it. This is essentially something that has just a cap on top of it, and then it's got a pressurized bag inside that just sprays out salt water. Now it's sterile, and we'll get to that in a second, why that's important. But it's just really easy. You can spray it in each nostril and then kind of blow your nose and just flush a lot of that stuff out. Now, the second one in that same first category is called a neti pot. Now, this is a similar concept but very different in practice. So here is a neti pot that I own and I use once in a while, especially in allergy season. You can see it has a little bit of like a genie in a bottle look to it. Mostly they fit about 8 ounces of fluid in them. You'll shake it up. First of all, of course, you'll add a packet of salt. So this is their official salt from the most common brand called Neil Med. So this is a package of a bunch of the salt packets. So this one has 50 of these pre-mixed packets in it. And then of course you need the neti pot itself. You'll dump said salt into the neti pot, and then you will add in about 8 ounces or so of clean water. So what do I mean by clean water? Well, that's sterile water you can buy at the store, or distilled water, or boiled water for 3 to 5 minutes, and then of course, for common sense, let it cool down first. You don't put boiling water up your nose, obviously. So why do we care about that? Well, the cribriform plate. I won't go much more into that because the risk is very low, but it's still something. Don't mess with just tap water or fresh water or anything like that. Make sure it's something that's safe. So how does one do it? You just take the neti pot with the said mixture, put it in one nostril, tilt your head usually forward and down to the other side, and you will get a high volume at a low pressure flow of water that starts to come out the other nostril. If you've pushed your head forward and tucked your chin, kind of flex the neck enough, it shouldn't go back to the back of your throat. It should just flush around from one nair to the other essentially and bring a lot of stuff with it. 4 ounces on one side, 4 ounces on the other side is kind of the standard. And there are some other regimens that people can do other than just the standard saline. I've seen people do clindamycin in here if someone actually has a bacterial sinus infection, and that would essentially be a local antibiotic course. I'm not recommending anybody do that specifically right now. That's up to you as a prescriber to figure out if that's appropriate for you or for your patient technically. So the next category of medication is a steroid. So this is an example of a nasal spray steroid. This is the generic for Flonase. This is fluticasone. Costco branded is what I buy just because that's the cheap stuff. And you can use it several times a day. Twice a day. You can use it up to a couple sprays per nostril twice a day. And what you really want to do is think about why you're using it. Again, I've had lots of people say just throw Flonase at them because they have allergies. Well, let's take a step back. Low dose steroid decreases inflammation. It shrinks things like swollen, boggy, erythematous nasal turbinates. Well, that's what we're trying to do. So if you look in someone's nostrils and their nasal turbinates are essentially right against the septum and there's very little room for mucus to get out, well, that is a risk factor for getting congestion that then can get into sinus infections. And it's just a poor quality of life like that too. So if they have swollen nasal turbinates, especially if they're almost touching the nasal septum, then Flonase is a good choice for you. Or any of the other nasal steroids most likely. Now remember, this is a very low dose of a steroid. It's a topical steroid too. So it's typically safe for people with systemic problems, but of course that's for you to decide as a provider for that individual patient. And remember, just think about how low of a dose it is. It doesn't typically cause Candida issues in people with competent immune systems. It's just, again, a low dose. And don't expect it to work on a PRN basis very well. It's just not designed to. So if a patient comes in and says, Flonase doesn't work, I used it once last week and I didn't notice any difference, well, that's not a failure of the medication. This medication needs time to do its job because it's so low dose. I typically start people on twice daily dosing and then tell them, don't even really expect it to be working even to notice it for the first week or so. If you do, great. If not, give it some time. In fact, one of the ENTs that I've worked with before said 3 months. That's the time frame when I'm going to say it's a failure or not. Until then, it's still working slowly. You'll probably hit a plateau, almost a plateau within the first month of, I think it's mostly working. And if you see them back or if they describe their symptoms to you, the majority of the effect will be early on in the beginning of the treatment, but just, again, it's not really a PRN medicine. It's very low dose, and it's specifically there to decrease the size of those nasal terminates and the swelling and open up some of those passages to let the mucus flow through. That's specifically why to use it, not just because, quote unquote, they have allergies. All right, so it's shrinking the turbinates and it's allowing more space to go through. Now the next one I like is, the one I specifically like is called azolastine. This is an antihistamine. Antihistamine nasal spray, which effectively makes it a local antihistamine for your nose. Now, this isn't to say that you don't also recommend the PO version of antihistamine. That will help with lots of stuff too. This is typically, in my opinion at least, an add-on on top of a PO antihistamine, especially if someone's already taken the full adult dose, like a 10 milligrams loratadine, Claritin, or full dose cetirizine, Zyrtec, anything like that, especially any of the second generations, or even the Xyzal third generation. This keeps me from having to have that patient add too many doses of PO antihistamines. It's typically safe to do, actually, to do, let's say, a second dose of Claritin or something per day. But you do start running into systemic side effects more, especially if you are a little more susceptible to the anticholinergic effects. You'll get dry mouth, dry eyes, things like that. Typically, you wouldn't expect too many QT, corrected QT prolongation issues with that second dose of PO antihistamines, but again, that's a case-by-case basis. It's up to you if you need to do an EKG or anything like that. But again, this specific antihistamine spray can help you not have to do that second dose of PO antihistamines. This, unfortunately, I don't exactly know the backstory as to why or anything, probably a patent issue, but it's prescription only in the United States, even though it's just an antihistamine. There's not a lot of rhyme or reason sometimes to it other than, well, this company made it and they made it this time and their patent's still there, so they decided it was prescription only. I don't even know why sometimes. But that's going to really help you to use daily during any of the pollen seasons, anytime that you're expecting to be around a source of essentially a trigger for you. So if you're around, or if your patients are around cats and dogs and that's really their trigger, then have it beforehand. I use it during pollen seasons twice a day in myself, and it seems to help a lot. Now, the next group of medications that I want to talk about is anticholinergics. So this is ipratropium that I like to use. I don't use this very often. I don't prescribe it very often. I don't use it very often myself, with one exception I'll get to in a second. This is actually certified to use for allergic rhinitis, and you can kind of use it off label for other uses too, like vasomotor rhinitis. So this is, again, an anticholinergic medicine, and so that's going to stop your rest and digest system, which typically produces secretions and mucuses and things like that. And so that's just going to dry up your nose. It's going to stop the production of some of the mucus and any of the secretions. So that's helpful. Studies have actually shown that this ipratropium can help alleviate some of the post-nasal drip cough. So as you know, the differential diagnosis for cough is quite broad. One of the things that's quite annoying for us to treat, because we don't have a ton of things to do for it, is the cough associated with post-nasal drip with viral rhinosinusitis, just because viral things we don't use antibiotics for, obviously, but this is something that's tangible that I'll actually give patients sometimes for a very short term to try to decrease some of the secretions and therefore decrease some of the postnasal drip that's coming down and irritating some of their cough receptors, etc., and producing that postnasal drip cough. The second reason I like to use this, well, really the third, so there's the allergic rhinitis, then there's the postnasal drip, and the third one I use it for is vasomotor rhinitis. So this is when someone's, let's say, in my example, putting on an N95, really crimping down that metal nasal bridge clamp, and you start to get basically just a runny nose. Not allergic. You're not allergic to the components in the N95, and in fact, after you're wearing the N95, you're essentially exposed to no outside allergens, so it's not allergic. It's more of just this local tissue response to all that pressure. And this anticholinergic really helps with that. I've noticed it. I've been using it right before I would put on one of those thick N95s, the healthcare grade N95s for an emergency department or anywhere in the hospital I'm working that day. And it's helped a ton for me. I've told it to a couple other people, and they actually find it to be useful too. Again, use it as case-by-case basis. This is prescription only, so you will have to provide that prescription to the patient if that's something that you think could help them, whether it's for, several steps in, if you will, for allergic rhinitis, or if it's for the postnasal drip after a viral rhinosinusitis, or even if it's for that vasomotor rhinitis with a mask. So I like it. Isn't for everybody. It is prescription only. The next one I'm going to use, I'll show you a bottle that I bought several years ago. and you can see it's still got the security seal on it. I've never used it before. This is oxymetolazone, also known as Afrin, brand name Afrin. That's the way most patients will tell it to you. And it's something I essentially never use. It's something I essentially never recommend to people. One of the ENTs I've worked with before would tell patients there's essentially one case scenario that he recommends it for, and that's right before someone gets on an airplane, if they have really sensitive inner ears to pressure, if they've had ruptured tympanic membrane before, or if they're really prone to eustachian tube dysfunction. So using this immediately before an airplane ride will help clear up the sinuses right in the area where all over, but specifically in the area where the eustachian tube connects into the sinuses, and help make sure there's no dysfunction there, that you can continue to equilibrate the pressure of your inner ear behind the tympanic membrane and your oropharynx, i.e. the same pressure as the cabin. So you won't get nearly as much of that popping sensation, especially if someone's really sensitive. Again, if they've ever had a ruptured tympanic membrane or anything like that, or if they're susceptible to it, can be okay for that. Now, Afrin, oxymetolazone, I'm not going to call it necessarily dangerous, but it is something to really watch out for. It does cause physiologic dependence, meaning if you use it for too long and then stop, you'll actually be worse off than you were before. So it is an alpha adrenergic receptor agonist, alpha 1, and then I think a partial alpha 2. And you have changes in those receptors once your body gets used to that medication. Afterwards, you get rebound rhinitis that can be worse than the initial insult for which you used it. There are Facebook addiction groups for this stuff. So I shy away from it typically myself. I shy away from it for my patients. Some people or some sources, depending upon what you're reading or listening to, will say 3 days max. Some will say 10 days max. Certainly some people have done okay longer than that, but I try to stay away from it for the most part. Again, eustachian tube dysfunction for a very specific use case scenario, probably totally fine, but certainly not long term, certainly not for an entire season, anything like that. Again, I've never once recommended it for allergic rhinitis. It really shuts down a lot of the secretions and all too, but again, we've got other ones that are pretty helpful for that too, and so why risk it typically? One more thing I want to make sure I mention is that trigger avoidance can be really helpful. So if you're really susceptible to pollen, staying away from pollen obviously is important. Using a mask is effectively trigger avoidance. So if you're going to be out cutting, weed eating or cutting grass, and you have a really bad grass allergy or tree pollen allergy just being outside for that entire time, well, wearing a mask can effectively isolate you from those allergens and help protect you from ever developing a response to something that never gets through the mask. So that's a really important part of allergic rhinitis too, is just keeping away from that in the beginning. On the indoors part of that, that means vacuuming regularly if you've got any carpet. Sometimes even if you can, taking away sources of carpet, going back to hardwood floors, anything like that can be helpful. Making sure you wash linen, obviously. When you use a vacuum cleaner, using one that has a good filter in it, like a HEPA filter, so it doesn't just suck up the pollen from the carpet and then almost aerosolize it, put it in the suspend it in the air for you to breathe. So that's helpful too. Lastly, don't forget about your colleagues in the community. So this is the otolaryngologist ENT, and this is the allergist. As far as the ENTs go, a lot of times people simply have anatomy of their inner nose that's just not amenable to a good quality of life, essentially. They will have a deviated septum that blocks a bunch of mucus, and they just are at high risk for always developing sinus infections or just always having problems. Send those people to ENT if you're worried about it. They can do simple outpatient procedures sometimes. They can do even inpatient, or not inpatient, but even ones that have to be done in the OR are oftentimes minimal surgeries, minimally invasive, that they can go in, they can shrink turbinate surgically, they can redo or kind of realign a nasal septum, and lots of different things that are mechanical problems with someone from their anatomy that really are the best way to go with that. So don't forget your ENT referral. Some people are just super allergic to everything, and they might need an allergy referral. With that allergy referral, they very well might get allergy testing to try to figure out if there's a specific trigger for them. And they also very well might get better treatment from that standpoint, oftentimes in the form of shots. And so if an allergy shot's available that can get someone to effectively be cured of a certain allergen over the course of several years of these shots, well, that might be the best quality of life that you can offer them, essentially, with respect to allergic rhinitis. And so getting them into an allergy referral is really important as well, if you think that's something that they can either afford, or something that the shots, for instance, would be long-term, even a viable plan. So some people it works, some people it doesn't. Just keep it in mind. So I hope that was a helpful video. That's my personal way of thinking through nasal sprays specifically for allergic rhinitis, and kind of thinking through the process in a stepwise, logical manner, instead of just throwing the kitchen sink at someone, expecting them just to blindly take everything. And the more you can explain your reasoning to someone, I think the more adherence to that treatment plan you'll typically get, and the more buy-in you'll get from the patient. And I think that's really important.